Imagine waking up one morning with a heavy, uncomfortable sensation deep in your lower abdomen. You head to the bathroom, sit down, and wait. Time passes. You push a little harder, still nothing. Maybe another cup of coffee will help, you think, so you leave and try again an hour later. Same outcome. By the third or fourth attempt, the situation changes, and it's not minor anymore. Now there's a persistent, dull, almost pulsating ache stretching from your lower back into your pelvic area. You feel bloated, full, almost feverish, and a quiet intuition whispers, something is seriously off. If this scenario feels all too familiar, pay close attention now. What follows could prevent a medical emergency that, left untreated, might become life-threatening. Let's start at the root of the problem, because understanding it is the first step toward resolution and prevention. What you're experiencing is medically termed fecal impaction, but in plain terms, it's when stool becomes lodged in the rectum and cannot move forward. Your large intestine, a tube nearly 5 feet long weaving through your abdomen, has one critical function: to extract water from what passes through it. Under normal circumstances, it performs this task with remarkable efficiency. The problem arises when stool remains stationary for too long. The colon continues to remove moisture relentlessly, turning what once was soft and manageable into a dense, hardened mass. Most people are caught off guard because this condition doesn't appear suddenly. It develops gradually, especially in older adults, often over 3, 4, even 7 or 8 days. Initially, discomfort may be mild. Slight fullness, minor sluggishness, maybe small amounts of bowel movement still pass, but much of the waste remains trapped. Picture attempting to force a rough, irregular stone through a garden hose. It won't budge, and the harder you push, the more firmly it lodges. This is exactly what happens in the lower digestive tract. Straining only compacts the mass further rather than clearing it. Age intensifies the risk. Beyond 60, intestinal muscles naturally slow down. Pain signals in the gut become less reliable. Medications like blood pressure drugs, painkillers, antidepressants, iron supplements, and even calcium reduce motility, and thirst sensation diminishes, leading to chronic low-grade dehydration unnoticed by the body. This scenario isn't a failure of the individual. It's a convergence of natural biological shifts that rarely receive proper attention. Fecal impaction can be confusing because its warning signs mimic other conditions. The first misleading symptom is watery discharge. When a solid blockage fills the rectum, liquid stool from higher in the colon may seep around the edges, creating what is known as paradoxical diarrhea. Many mistake this for a gastrointestinal infection and reach for anti-diarrheal medication. This response is dangerous. Medications that slow intestinal movement exacerbate the impaction, allowing the hardened mass to grow and worsen. A second symptom often goes unnoticed: urinary issues. Difficulty urinating, painful trickles, or frequent urges with minimal output occur because the rectum and bladder share a confined space in the pelvis. A distended rectum presses against the bladder, partially obstructing the urethra. In severe cases, this urinary retention itself can become an emergency. Lower back pain is another commonly misinterpreted sign. Aching in the lumbar area often leads people to assume muscle strain or arthritis. However, significant rectal pressure radiates pain into the lower back, thighs, and hips. Any unexplained back discomfort combined with bowel irregularity warrants immediate attention. Older adults may also experience sudden changes in mental clarity or confusion. Studies show that substantial bowel obstruction can manifest as cognitive disturbances in seniors, further complicating diagnosis. Understanding these mechanisms is crucial. Recognizing the gradual progression, from mild discomfort to severe blockage, paradoxical diarrhea, urinary difficulties, radiating back pain, and cognitive changes, allows early intervention before a potentially life-threatening crisis emerges. Fecal impaction is not an abrupt accident. It's a slow, predictable process that can be mitigated with awareness and timely action. Disorientation, subtle confusion, unexpected restlessness, these are signals your body can send when it is under intense physical stress and discomfort. In some cases, early toxin buildup contributes to the change. If an older family member suddenly seems mentally off without any clear reason, their bowel condition must always be considered as a potential factor. Let's be direct. Fecal impaction is not a minor nuisance or a problem that can wait out. It is a true medical emergency. Ignored, it follows a predictable, escalating sequence of harm. Initially, the intestinal wall, which is living muscle, stretches beyond its functional limits. Blood flow to the overstretched tissue diminishes, and the muscle loses its ability to contract and propel waste. That section of bowel essentially goes silent, a state known in clinical terms as ileus. As pressure continues to mount, the distension may extend higher, affecting additional portions of the colon. What begins as a localized rectal blockage can escalate into a broader colonic obstruction. Nausea and vomiting emerge, abdominal swelling becomes apparent, and the individual appears and feels seriously unwell. Stage 3, the most critical, is bowel perforation. The intestine has a physical limit to how far it can stretch. Exceed that, and the wall tears. When this occurs, fecal matter, bacteria, and digestive toxins spill into the sterile abdominal cavity, causing a rapidly progressing infection called peritonitis, which is life-threatening. Without immediate surgical intervention, death is inevitable. This information is not shared to frighten, but to make clear how urgent the stakes are. The gap between a serious but treatable condition and a fatal emergency is narrower than most realize. From the inside, the danger zone manifests through specific, unmistakable signs. A rigid, board-like abdomen that is tender to the touch. A fever above 101 degrees Fahrenheit. Sudden, severe abdominal pain that is constant and intensifying, not crampy or intermittent. Total inability to pass gas, persistent vomiting, or a sudden drop in blood pressure with confusion and clammy skin. These are not symptoms to monitor. These are emergencies demanding immediate attention. Now let's move from understanding the danger to knowing what to do immediately. Knowledge without action has no power. First and foremost, stop straining. Cease all attempts to force the stool out. Straining increases intra-abdominal pressure, irritates already inflamed tissue, and risks hemorrhoids or minor rectal tears. No amount of effort on the toilet ever dislodged a hardened blockage. Straining does not work. End of story. Step 1 in intervention is lubrication and softening with glycerin suppositories. Adult glycerin suppositories available over the counter are your first at-home tool. A single suppository rarely suffices for a substantial blockage in adults. Typically, 2 to 3 are required to adequately coat and soften a dehydrated mass. Here's the proper method. Lie on your left side. This left lateral decubitus position aligns the sigmoid colon and rectum to allow gravity to help rather than hinder. It also relieves direct pressure on the rectal area. Apply a generous layer of water-based lubricant to each suppository before insertion. The rectal tissue is already inflamed, and dryness makes the procedure more painful and less effective. Gently but firmly insert all suppositories as deeply as possible, ensuring they contact or sit alongside the hardened stool rather than near the entrance. Then remain still for at least 30 minutes, ideally 45. This allows the glycerin to melt at body temperature, penetrate the mass, and stimulate the rectal wall to produce its own secretions. Jumping up too soon achieves nothing except wasting the medication. After the wait, rise slowly, go to the bathroom, and allow your body to act without forcing anything. Movement is ideal, but if none occurs, remain calm. Step 2 is rest, gentle walking, and repetition. If the first attempt yields no results, take an hour to recover. Move lightly around the home, sip a full glass of warm water. Warmth relaxes intestinal muscles. Then repeat the suppository procedure. Often, the first round softens the outer layer, and the second penetrates the core of the impaction. Step 3, if home measures fail, is seeking medical care without delay. Completing 2 full rounds without relief, or experiencing any emergency signs mentioned earlier, necessitates urgent care or an emergency room visit. This is not defeat. It is the proper clinical choice. Hospitals provide high-volume clinical enemas delivered under controlled pressure, reaching further into the colon to break apart the mass. Imaging tools assess the extent of blockage and evaluate the bowel wall for risk. Step 4. If all else fails, is manual disimpaction performed by a specialist. This procedure involves physically breaking up and removing the hardened stool digitally, using gloved, lubricated fingers. In severe cases with inflamed surrounding tissue, sedation, or anesthesia, water is by far the single most crucial factor in preventing stool from hardening. The large intestine's main function is to reclaim water from waste. When your body is chronically underhydrated, the stool simply cannot retain enough moisture to remain soft as it moves through the colon. The challenge intensifies with age because the natural thirst mechanism declines. You may feel entirely fine, experiencing no urge to drink, yet your cells can remain persistently dehydrated. The practical guidance is clear. Do not wait until thirst hits. Aim for 6 to 8 glasses of water daily, beginning with a full glass immediately upon waking, before any food or drink. That first morning glass triggers the gastrocolic reflex, a gentle wave of intestinal activity prompted by fluid entering an empty stomach. This simple, drug-free mechanism is one of the most effective ways to encourage predictable morning bowel movements. Movement plays an equally essential role. The intestine is far from a passive tube. It is active muscular tissue, propelling waste through rhythmic, wave-like contractions called peristalsis. Physical activity directly stimulates this process. Even a 20 to 30-minute walk after meals, performed at a comfortable pace, has been clinically proven to accelerate intestinal transit significantly. For older adults with limited mobility or chronic pain, alternative options like chair exercises, gentle yoga stretches, or simple torso rotations help maintain intestinal muscle activity. Extended periods of sitting, particularly after eating, remain one of the most overlooked contributors to constipation in seniors. Next, medications demand careful review with your physician. This is non-negotiable. Numerous commonly prescribed drugs, including opioid pain relievers, certain calcium channel blockers for blood pressure, iron supplements, high-dose calcium, antidepressants, diuretics, and antihistamines, can dramatically slow intestinal motility. This does not mean stopping your medications, but rather engaging in an open, detailed conversation with your doctor about their impact on bowel function. Ask directly if any current prescriptions could contribute to constipation, and if alternatives exist that are gentler on the digesti. Thanks for watching. See you in the next one.